All y'all live and in person. Woohoo! It's great to see everybody. So, in healthcare, there isn't as much meaningful or standardized outcome measurement as anyone in this room would like. However, even with a general paucity of outcome data, there's very clear and substantial evidence of unwarranted variation in care and significant disparity in health outcomes. It's not okay, and we can change it. But like planting a tree, the best time to start would have been long ago, and the second best time is now. The evidence of inequity is strong enough that if you don't have outcome data, you should assume that you and your organization contribute to the problems. Yet, a more common assumption is that the cause is someone else or something outside of medical care. And while there are contributors to disparate health outcomes, well, these things are contributors to disparate health outcomes, the point is that they're not an excuse for failing to address disparity in your patient's outcomes. Widespread, standardized outcome measurement could be a first step, but it hasn't happened fast enough. In redefining healthcare 15 years ago, I made the point with Mike that outcome measurement illuminates inequity, so every clinician or team should participate in measurement and drive improvement that reduces disparity. We believed that illuminating inequity at this level would spur widespread action to eliminate disparate health outcomes. But outcome measurement is not yet normal, and inequity rages on. So, while standardized outcome measurement will surely help, we can't wait for it. None of these panelists are waiting for standardized universal outcome measurement. They're working to eliminate disparity now. So, Dr. Willie Lawrence is a Harvard-educated cardiologist who's board certified in interventional cardiology, nuclear cardiology, cardiovascular disease, and internal medicine. He is medical director of the Center for Better Health and Wellness in Benton Harbor, Michigan, and medical director of health equity for Corewell Health in St. Joseph, Michigan. And for 30 years, he's volunteered as an expert for the American Heart Association, where he's held many impressive roles. In 2022, Dr. Lawrence was named AHA chairman of the Oversight Committee for AHA's initiative to help improve COVID-19 related health outcomes by reducing high blood pressure among racial and ethnic populations in federally qualified health centers, a project for which AHA was awarded $32 million by the US Department of Health and Human Services. Dr. David Buchanan is the Chief Clinical Officer at Oak Street Health, where he practiced primary care since 2017. He leads Oak Street's clinical and technology efforts to improve quality and effectiveness. Dr. Buchanan was educated and trained at MIT, University of Chicago, and University of California, San Francisco. Prior to Oak Street, he held clinical leadership positions with a public hospital, community health center, and a health IT network, and a Medicaid ACO. Importantly for this panel, Oak Street Health offers primary care for seniors on Medicare with a mission of rebuilding healthcare as it should be. It's a for-profit organization with about 165 centers in 21 states that's won awards for how it treats both its customers and its providers. And over 50% of patients at Oak Street identify as African American, Latino, or Indigenous, and about 60% of its providers identify as being in racial minorities. Over 40% of Oak Street Health patients are eligible for Medicaid, meaning they have low financial resources. Dr. Rebecca Weintraub was educated and trained at Yale, Stanford, and Harvard, and is the founding director of the Global Health Delivery Project at Harvard University, and she co-leads the Global Health Delivery Intensive. She's an assistant professor in the Department of Global Health and Social Medicine at Harvard Medical School and an associate physician at Brigham and Women's Hospital. She launched the Better Evidence program at Ariadne Labs to design, test, and scale strategies to equip the current and future healthcare workforce with the latest evidence to improve health outcomes. During the pandemic, Dr. Weintraub supported public health decision makers to deliver COVID-19 vaccines, which I think she's still doing. Yeah? So each of you work in pursuit of health equity from different points of leverage. So where we discussed starting was if each of you would introduce us to the work that you do and tell us, based on your work, with the current state of measurement and data, what action can leaders here be undertaking? David, you want to get us started?
Sure, I'd be happy to. It is a pleasure to be here before I get started, to be with this group. I think I've learned from hanging out with ICHOM folks that value-based care is a very small thing in the United States, but very big elsewhere. So it is a pleasure to be here so I can learn from all of you who are probably 10 steps ahead of us and see where our future lies. I am, as Elizabeth said, Chief Clinical Officer, a general internist. I see patients 1 day a week and then support the development of our care model to advance our patients' outcomes. Our motto, as you heard, is to rebuild healthcare as it should be. And certainly that includes addressing disparities as well as improving the outcomes for our entire patient population. And I would say, you know, to boil it down to some statistics and things that we're most proud of, if you look at the Medicare benchmarks, so this is the program for seniors and people with disabilities in the US, we have reduced hospitalizations for our entire population of patients by between 40 and 50%, depending on the month. So we're really proud that we've not just accomplished that in certain subgroups, but across all of our patients. And because, as you heard, we target low-income communities and low to moderate income communities where the greatest health disparities lie, we believe that by improving the outcomes, we will also address disparities. Just to give you a little bit more color on how we're different, I don't know how this will relate to how primary care is done across other countries, but when I'm in clinic, I see about 10 to 12 patients per day, which is probably half of what a normal general internist in primary care would do in the US. I have a dedicated medical assistant and scribe, so someone writes my notes, someone gathers all the information from the computer that I need, outside information. The medical assistant does a ton of standardized assessments on patients so that when I see them, we already have a good sense of the broad issues. But I also have a social worker, a nurse, a community health worker, a therapist, someone to help the patients navigate insurance issues, and free transportation to and from our centers, as well as we have a community room that we use for bingo and celebrating people's birthdays and having a local jazz band come and perform for our patients. And so we try to create community. We have robust teams, and we see people very frequently because I think value-based care in the United States is very focused on cost containment because probably this group has noticed that we have a massive cost problem in the United States, but at the end of the day, we believe that value-based care is even more about improving the outcomes for our patients. And we've made, over-invested, you could say, relative to the norm in primary care to try to drive upstream outcomes, including avoided hospitalizations. So that's a little bit more about me.
Rebecca?
Well, thank you so much, and it's a joy to be here with Elizabeth. I think many of us have been in classrooms with Elizabeth as she's leading sessions and asking you very direct questions. And one of the reflections I've had in thinking through the pandemic and lessons from the pandemic is the leaders that I work with, their interest not only is to ensure the promise of today happens, can I ensure the patient's safe, their screenings occurred, but obviously the scale and equity with which they want their service delivery to occur. And the pressure that we have found from the ministers of health that we train, the emerging leaders, the heads of lab, is how do I actually think of that upstream work? What does the data infrastructure, the data preparedness part of my leadership role, how can that look different now that I have unfortunately emerged from the pandemic? And in that conversation, we talk to many folks who say, I appreciate the standardization and I need the localization of the data. I need local data sources to inform not only will I serve this vulnerable community, but block by block, provider by provider, whom do I serve and in what order? And I think when we say and think about kind of how do we measure equity, it's the speed and scale, the dimensions of equity, and how do we sequence that work. I think one of the things that we're hearing about in thinking through kind of the bucket of clinical medicine, surveillance, is what do the data agreements need to look like now? So we have the right data to be measuring the equitable interventions in the near future.
Cool. Really?
Sure. Thanks for having me here. I'm an interventional cardiologist, and you're probably wondering what is he doing up on the stage?
No.
But I was a kid that grew up on the east side of Cleveland. Happened to go to a boarding school not far from here. And then I spent 12 years at Harvard and 4 years at Hopkins. Thought I'd be a researcher and decided that I wanted to practice cardiology in a community that looked like the community I grew up in Cleveland, Ohio. And I ended up in Kansas City. And I spent the next 30 years in Kansas City serving a community that looked a lot like the community I grew up in as an interventional cardiologist. And then George Floyd happened, and it made me sort of rethink some of the things that I had been doing. It made me ask a lot of questions. And I was talking with a very good friend of mine who did work in Michigan. And her healthcare system, Spectrum Healthcare, after George Floyd happened, they hung up a sign that said Black Lives Matter, and they committed $50 million to issues around health equity, and it got my attention, and I decided I wanted to go join them for the ride. And I moved to downtown Benton Harbor, which is predominantly black, poor. It lost its hospital 30 years ago. It's across the river from St. Joe Hospital, where Spectrum Health is. Spectrum had ignored it for many years, and decided they wanted to make a change. With CARES money in November of 2020, I think it was, they created what's called the Center for Better Health. It's a 1,200 square foot space in an old bank building. There are 4 marijuana dispensaries within 2 blocks of the center. This gives you a visual. It's called the Arts District, and I have an apartment that's over a used record shop in downtown Benton Harbor. And we started doing work focused more on the social determinants of health than on what I did every day. So it's been an interesting process. And in the midst of all of this, I got a call from Nancy Brown from the Heart Association telling me about this new initiative. I mean, I've done a lot of work with the Heart Association over the years. It's National Hypertension Control Initiative, where the federal government, through HRSA, gave $92 million to 250 federally qualified health systems across the region to help build up, improve hypertension control, hypertension being an important a risk factor for death and hospitalization from COVID. The goal is to improve blood pressure control, and especially using technology, Bluetooth technology, as a platform for getting information from the patient to the clinician. We've learned a lot of lessons from that. We're focused on outcomes and trying to know how to measure outcomes, and we do that both for the NACI, but also for our work at the Center for Better Health. So it's been an interesting transition for me from someone who got up every third night putting balloons and stents in folks to really trying to do the things that I think potentially make people healthier. And my realization that hospital care, English, hospital care ain't health care. So it's fun to be here to learn more about outcomes and what you guys do and how you close the gap between the things that happen here and the things that the clinicians are doing at the bedside. Because right now there's a gap. Folks don't know about the work that we do around health equity and the importance of that work to achieving better health.
Thank you. So I'm going to ask them one more question to give you a little more context on their expertise and what they have to offer, and then we're going to open it up so that you can ask them questions, because it's a pretty great panel. So we know that unwarranted variation in outcomes, health disparities, and inequity are huge problems. To address them effectively, we are going to need transformational change. So what's the role of standardized outcomes measurement in promoting equitable and inclusive care? Will, you want to start this time?
Sure. One of the guiding values of the American Heart Association is that you have to meet people where they are. And in order to meet people where they are, you have to know who they are. And I think that there is a tendency when we see patients in the office, we see somebody across from you who's black or white, that's what you see. And what we come to understand is that we use race as though it somehow is really a reflection of our genotype, and race is really a social concept. It has more to do with phenotype, very little to do with genotype. So in order to know who's actually sitting across you, who this patient is, you have to know other information about them. You have to understand where they are in their life journey, what else is going on in their lives. I mean, I'd see a patient and I wonder why her blood pressure wasn't in control, and I'd see Mrs. Jones, and so I'd say, Mrs. Jones, why don't you just jump up on that table and your blood pressure's high, do the right thing, here's a prescription, and I thought my work was done. But what I needed to understand was what else was going on in Mrs. Jones's life, and these are issues that a recognition that it's not race that leads to disparities in healthcare. It's racism that is the crisis. Racism and redlining and all these other things that happen. Education, and it's important to understand that patient beyond race. And I think we have to be able to measure those things, and we have to ask the right questions, because if we're going to meet people where they are, again, we have to know who they are, and what we're doing around these types of measurements is incredibly important to look beyond just race, but other things that represent this patient as well.
Yeah, race is a fiction, but racism is a harsh reality.
Yeah.
Rebecca?
I always think in my hospital, the week before the inspectors are coming, all the things that we do so well, all the process metrics, how we keep the wards, how we do our documentation, and why that's not standard practice throughout the other 51 points of the year. And that's because we're being measured at that point. We're worried that we're about to be measured. And without this level of measurement, we'll have this unspoken amount of variability in care. I also note that the next generation, the trainees that I work with, they're eager to be measured on the quality of the care they're delivering. They don't want to see the variability. They want to be able to do a pass off to the next clinician and see that they've followed that care delivery value chain, for example. They want to understand the outcomes that the patients had when they've been discharged home, or they've been brought to our home hospital system, for example. So I also see that energy of that measurement guiding the light of who's coming into the workforce. And what I hope is actually decreases burnout. If you believe the inputs that you're providing actually lead to better outcomes, we're going to attract and retain the workforce that we so desperately need at this moment in time.
That's well said by both of you. I think to add to that, I would say that, looking at the right outcome measures that we work against is one of the primary focuses of ICHOM, and that's really critical that we find the right things to measure. I also agree that when we have measures, even if they're not perfect, as they probably never will be, the discipline that comes from having those measures and then continually putting them in front of folks, especially when we aggregate those outcomes according to groups that haven't done well historically, and just continually looking at it creates a lot of action. And I really think that a lot of what we need to do in addition to the measurement is develop skills for how to address the disparities that exist. And if you don't have the awareness and the kind of continual focus that measurement and reporting can create, you just won't even learn the skills of how would you think about how to address the needs of the people that are falling behind, as opposed to thinking about how to address things kind of for all, which often, as we know, almost never produces outcomes for all. So I think showing measuring things, even if they're imperfect, getting them in front of people, developing the discipline of saying who's falling behind and how do we address this particular needs of that group is absolutely critical to make progress.
Do you guys want to build on what each other said before we open it to questions? Is there something you're dying to add?
I sometimes ask who's not in my queue. Which populations have I not served? And then how do I ask my trainees to sort through how would we find that data?
Yeah. Or how do you reach those people who aren't your patients but would benefit from being there? Yeah?
One of the things that I found after I moved to Ben Harbor, my focus was on urban Black, and I actually have clinics in Niles, Michigan, and also Cloma, which are rural places. And I just as I studied these issues more and more, issues of disparity and equity, you realize that the disparities that exist in the inner city they also exist in rural America, and it's complicated by issues of communication. It's not so easy to roll out a Bluetooth device when you're not connected. But we found that, and also when we opened up our center in Ben Harbor, it's a little 1,200 square foot space, we found that people from those communities actually came into Ben Harbor. We got more and more attention, and then in January we messed around, and now Whirlpool has given us a 26,000 square foot building. Now the system had to put in $5 more million to build that up, so we're making progress. But again, the thing that I really have come to notice as I've gone into these rural communities is that there's so much commonality to these problems. The solutions may be a little bit different, but a lot of the problems are pretty ubiquitous. So.
Yeah.
One of the things I really love about being at Oak Street is that we really focus on the broad panel of patients that we're assigned to, and I know it's a little different than in some other countries, but when we take global capitation on all of our patients essentially, and so we, as a result, we have to know exactly who the patients are, and we have systems and processes between us and the government and the insurance companies to know exactly who our panels of patients are, and it really helps us not just focus on the folks who are right in front of us, in the clinic, and often the folks who successfully get in are the folks who need less help than the people who are not there. And so we, have done things like set aside time for all the care team members to look at who is high risk based on, machine learning algorithms and things, as opposed to just, taking care of the people who successfully navigated whatever the access systems and successfully got in to see us. And that helps us provide some balance in, both we still want to provide the best care possible when people are in front of us and bring all of our talents and skills to the table, but also to zoom out and say, you know, the folks who are probably falling behind the most are not those folks that are in front of us, and now what? Part of what we do, you know, day to day is try to help clinicians change that mindset, you know, and open up their creativity a little bit to figure out how to problem solve for folks that they can't put the stethoscope on or write a prescription for in this moment.
You ready to open it? Okay, so we are then open to questions. Okay, I can see, I may need help with whoever's running because I can.
Hi, my name is Gabriela Prada and I work for Medtronic, it's a medical technology company. My question is, so I understand absolutely the need to understand the outcomes of different ethnic groups, right? And not only from a management of disease perspective, but also from a prevention perspective. And you mentioned about data localization. We have been told by Microsoft that we probably possess the largest repository of health data that exists, that it comes from a lot of the devices, and we have the opportunity to use that data and use artificial intelligence to try to screen for potential problems and intervene before we can do that. Now, the potential is there, but there are tons of data issues that really are a barrier for us to do that. So I wonder, one, if you have experience in terms of data agreements that could work in this particular case, because everybody wants data localized in their own places or their own countries even, and that's extremely expensive. That's not going to happen. So what are the solutions? How can we look at that? And if you have any recommendations for us to explore this with policymakers. Thank you.
You want to start, yeah?
I mean, gosh, what a gift, absolutely. I'm going to find you right at the end of the hour. So I'll give you an example. So we built something called the Vaccine Planner. So if you go to vaccineplanner.org right now, there's an every week public data release where we're looking at active vaccination sites across the United States of America and the territories. And then we worked with Google so that you can go directly into Google Map and find the provider, their location. And then my team built out the front end so you can actually visualize what is a vaccine desert. Where are the folks that need to drive, use public transportation, and then who's the provider in that vaccine desert that is not vaccinating this week? And what I would say is it's in these public data releases so that we can visualize them different for different needs. These vaccine deserts are primary care deserts where Oak Street Health should be expanding, for example. They're reproductive health justice deserts. And I think it's when we layer the data sets on top of it and then interpret it for that public or jurisdiction leader, how do you plan for equity? You mitigate against deserts, for example, is the way forward. So pleased to talk and think through ways to layer on Medtronic's data.
Yeah, it's a wonderful question because from a value perspective, we're always talking about how the med tech and life sciences companies can change from thinking about the people they work with as customers to thinking about it as partners to achieve higher value together. And you're pointing out that it can be done to achieve higher value and to do that in ways that are inclusive and equitable by having a richer data set available. So thank you, it's a great question. Is that Jan? The other, yeah, Dr. Hazelset?
Yes, thank you. Despite the fact that the panel is coming from the US, we have our share of inequity also in Europe. So don't worry about that.
Yeah, so I will tell you that this panel has had a sort of accordion experience. There were two other panelists originally who have gotten sick with COVID or otherwise unavailable. It wasn't intended to be a US panel.
I was just joking.
My apology.
I was especially intrigued by your statement from Dr. Lawrence about who is sitting in front of me. I want to know the patient much more and deeply, to personalize it more. And hypertension is, to my knowledge, more or less a symptom instead of a disease. And most of the time it's reflecting bad lifestyle. And I think that we should try to invest much more in influencing lifestyle and incorporate it more in our healthcare as well. So that prevention, but then prevention directed about lifestyle, is part of our care and also reimbursed by the insurance companies, and not just a prescription of an anti-cholesterol drug, but really influencing lifestyle. Is it something which is also acknowledged by the panel members?
Yeah, lifestyle is fundamental to management of prevention of hypertension and the management of hypertension. At the Center for Better Health, our focus is the 80%. It's the social determinants of health. For instance, one of the things that we're actually trying to do, one of the things that we did in Kansas City was we developed an integrative medicine program. So we are focused on the things that are happening in people's lives, their lifestyle, but also trying to bring in different approaches to the management of hypertension. It's not approaches that aren't just dependent upon pharmacology. So I absolutely agree with you that again, lifestyle is lifestyle and lifestyle medicine. It's fundamental to the management of hypertension, diabetes, and all the other things that primarily impact communities like the community of Ben Harbor.
And is it possible to do this together with city councilors or with the city or the district itself? Is that a possibility?
Well, City Council of Ben Harbor, that's a complex issue. Yeah, government it's a challenge sometimes, but it's an important challenge. And one of the biggest challenges when you're going into a community, I thought that, I'm dedicated, come into Ben Harbor for all the right reasons, I'd be immediately embraced by this community. And the hardest thing to do is build trust. And it's so incredibly important when you start doing what we're trying to do, because this community fundamentally does not trust the healthcare system that I came to work for, and the city council that doesn't trust us either. So I've spent a good part of the year working on that, and I feel very honored that Mayor Marcus Mohammed 6 months ago called me and asked me to be the medical director for the city of Ben Harbor, and it made me feel as though I was making some progress in a really important issue. But I agree with all those things that you said. This is hard work, and we see it too in the other hat I wear with the National Hypertension Control Initiative. All these issues are pertinent there as well. And fundamental to the algorithms that we develop for managing hypertension to be used by pharmacists or nurse practitioners. Foundational is this notion of lifestyle and influencing lifestyle and meeting people where they are and understanding things that are happening in folks' lives that you can impact.
David, you guys are creating community centers as part of your care. You've got to want to add to this.
Yeah, I'd be happy to. I think one of the toughest things about my job as a clinical leader for an organization like Oak Street is that there are a lot of ideas on how we can make things better. And frankly, with how extensive the literature is in healthcare, there's a lot of even evidence-based strategies that are out there. And so people will say, well, why aren't we doing this? Why aren't we doing that? And I think that ultimately, if you start with the discipline of having the outcome measures that are most important, then you can try different things and see how much progress you're making against those, and what is the most efficient way to reach those outcomes. And I think testing out whether lifestyle, you make better progress than with medications or vice versa, or what's the balance, or how do they fit together, is the kind of things that we should be testing. And once we have really clear outcome measures, then we can start to work against it. If I even just think about the last 5 years at Oak Street, there have been times when we had really clear outcome measures, especially recently, I would say, and then other times where it wasn't entirely clear and people were trying to solve different things and jumping in different directions. And so one of our number one metric for the entire company is admissions per 1,000 patients. We literally look at that every day. and we're trying to prevent avoidable admissions. That's really like the thing we all focus on. And so now we do, not always, but sometimes we do things like randomized trials to say, how did this work to make admissions better or not? You know, if it works, let's scale that up. If it doesn't, let's take those resources and put them into the next idea. And it's a long process, but I think if we have that focus and we keep iterating against it and see what makes progress, we'll know how to make our investments within healthcare. And for places that have more flexibility across sectors of the government, then hopefully you can also, you know, assess these things across sectors.
Okay. Questions? Here I can see. We could use a microphone way up in front.
I have a question in the meantime.
Okay. We'll get you next.
We often talk about how payers can get engaged in value-based care. And Dr. Buchanan mentioned that capitation requires understanding demographics. So I'd like to hear more about how payers can support health care equity and value-based care.
Well, I'll start with that. We at the Heart Association, we've been very interested in this question, and actually there was a project between the Heart Association and Duke Margolis Center around this issue of value-based care. And how do you get physicians and hospital systems to be more interested in preventing disease than treating disease? I said before that, you know, that one of the things that led me to moving from where I was to where I am now was this belief that hospital care is not health care, and that primary care is incredibly important to what we're trying to do, but yet it's not reimbursed the way. You know, again, I ran an interventional program in Kansas City, a cardiology division in Kansas City. If you got a project that involves radiofrequent ablation for atrial fibrillation, you can get like hundreds of thousands of dollars, and nobody's going to lose any sleep. You try to get $10,000 to set up a preventive program for high blood pressure. It's really challenging, and I think that as a primary care doc, you're expected to see, not like your situation, you're expected to see patients every 15 minutes, and it can take 15 minutes to figure out what blood pressure medicine someone is on when they have high blood pressure, and we need to change that. We need to, if indeed we believe that hypertension is something that needs to be managed more aggressively, then we have to reimburse better for that work. So we just have this imbalance of what is value based upon, you know, RVUs, relative value units, which is what drives so many physicians. Unfortunately, that's what our pay is based upon. And when you get you know, many more RVUs for doing advanced procedures that don't necessarily make communities healthier than you do for doing the important work, the blocking and tackling that occurs in providers' offices every day, you get the results that we have, and that has to change if we want to see different outcomes. So.
Rebecca, did you want to? Yeah.
I'll just add, I mean, I think one of the roles that payers can play is setting out additional incentives. So we were talking about the shingles vaccine earlier as a group. And if we think of the unfortunate number of folks over age 65, over 75 in the United States who missed a shingles dose, if a payer said to a health system, find those patients and vaccinate them, we would be creating value, we'd be creating standardized measurement to find those folks, and obviously we'd be decreasing the admissions for shingles. And I think these are these moments where we've taken many steps back, not only in screening and prevention, but detection. And the payers can set up these incentives that would, in a sense, reserve our hospital beds for those that we need, and then improve the health outcomes, especially for those over 65.
I think I agree that, you know, because payers have the money, essentially they have a very unique opportunity to set up those incentives and kind of say, well, we're gonna keep paying you, but we're gonna pay you instead of for our view, or maybe we still pay you somewhat for our views, but we're gonna reserve some of the money for outcomes. You know, that really shifts things. I know for us internally, like during COVID, we, you know, obviously when the vaccines came out, it was like a massive opportunity, and we were, you know, like everyone else, and especially places that take care of seniors like we do, you know, we had, you know, just countless deaths, you know, on a daily basis from COVID, and we also were paying for all the hospitalizations. So it was a massive financial challenge as well as a public health and equity challenge. So when the vaccines came out, and we knew that if we vaccinated, you know, patients, that it would both save their lives and save a ton of money that we were paying out for hospitalizations. We did things like buy, you know, freezers that could, you know, the super cold freezers that could store the Pfizer vaccines and things like that. And, you know, like we're making quick decisions like, do we spend $30,000 for this freezer, you know, to stick in the back room at one of our centers? And we're like, yeah, we're gonna do that. And so, you know, because of those kinds of decisions we were able to make, because we knew that the dollars, we were gonna spend the money anyway. We either spend it on freezers or we spend it on hospital stays. We, you know, we built an infrastructure that allowed us to give more COVID vaccines than any other. The only health systems in Chicago where we were founded that gave more COVID vaccines than us for these, you know, multi-billion-dollar, multi-hospital systems. And we were, you know, we had a couple of dozen centers, and we were giving almost the same number of vaccines across our the communities, and because it was we knew that not only was it an imperative from a public health perspective, but also, you know, we had a financial imperative too. So I think those incentives are super powerful.
So when you think about things that a funder can do or a payer can do, you know, you can give an additional payment for participation in outcome measurement, in patient-centered outcome measurement. Not necessarily saying you have to achieve over this level, just saying you need to do it. In the Netherlands, DRGs now have a component of a requirement to participate in outcome measurement. And you know, in some isolated examples, there are requirements that you achieve over a certain level in some particular types of care and in some countries. The other thing we've seen during COVID is that if you're doing a bundled payment or a partial capitation or full capitation, those clinicians have funds that are coming in continuously through something like a pandemic. Whereas if you're only doing fee for service, all of the incoming funding gets very upset during something like a pandemic. And so in terms of supporting ongoing continuous care, you want to be doing either capitation or partial capitation or condition-based bundles to support ongoing continuous care for people. So those would be others examples. Have you got a mic down here now? There we go.
Hello? Yeah, yeah.
There you go.
Thank you. My name is Carolina Varela. I come from Spain. At the Hospital Universitario de Octubre, we are trying to make a change toward value-based healthcare. And I'm a public health specialist, so I'm delighted with the discussion. Thank you very much. So I got a question. I would like your reflection on one point that is bothering me. Is about data and about algorithms. And I think one thing that value-based healthcare can help with is that if we use to algorithm, artificial intelligence, the data we have already, it's biases. You were saying that, Dr. Lawrence, because we are racist. We are. The people is racist. So we write down not me, I mean, but we write down our prejudice in the electronic health records. And this is the information that the machines are going to learn and suggest decisions for the clinician. So it's an important issue. So my question is, don't you think that measuring prompts, which is the primary source of the information, is the patient, not the clinician? I didn't mean also that all the clinicians are racist, by the way. Sorry, my English. But if we measure this from the primary source, we are avoiding a lot of biases. So we will have this information that we are lacking in some areas. And in fact, our patients literally said to us, there are some things I don't tell my doctors because they did enough already saving my life. But I will tell this to a questionnaire. So don't you think this is an important, silly point of the value-based healthcare that can help equity?
I think you get to this whole issue of trust that I talked about earlier in terms of, as I understand your question, the hesitancy in certain situations of patients providing information to the providers, and it's a challenge, and especially with our electronic medical record systems. We've come to understand that we can't trust a lot of the data that's in there, and we spend a lot of time, our population group spends a lot of time trying to figure out how to do a better job of getting accurate information from patients who in many situations don't trust the people who are asking the questions.
Certainly true. I think I love your point. I think that gathering patients' information will help address some of those biases. I think a lot of what we do has nothing to do with machine learning, and so it's not exposed to some of those biases. We just look at who needs this service and who has not received it, for example, and just kind of and of course, because of the disparities and the biases in everything, if we just look at who hasn't received this, then we are addressing the needs of the people who are also falling behind. And so also, we do use machine learning algorithms sometimes to, more finely hone some of our interventions onto the people that will have the greatest impacts. And so when we do that, we have to acknowledge that there's biases in that, as you said. We also, another thing we do is try to look at different types of measures that are less biased. So certainly, because of our financial contracts with payers and the government, we have to look at the total cost of care, but we know that total cost of care measures are biased systematically. And so we also look at things like mortality, which are, maybe are definitely biased too, but not in the same directions in terms of who dies and who lives. So when we mix these things together, we can at least mitigate some of those things in our models to make sure we're not getting too far off. But at a simple level, if we just say who hasn't gotten this, I think that helps.
One of the lessons that we learned in the this National Hypertension Control Initiative with the Heart Association, I said before that it's based upon this management of hypertension in federally qualified health systems. We, based upon this MAP concept, measure accurately, act quickly, partner with patients. The P is incredibly important. It's the partnering with patients, and we've learned that partnering with community organizations that are trusted is a way to influence our patients, to get them to trust us, to get information to them, information from them. So that P, that partnering with patients and recognizing that we have to use some non-traditional sources of help and looking for allies in this work that we do is incredibly important. But again, building trust, and through whatever mechanism, it's important to getting good data.
And David, you made a point when we were speaking earlier that that part of achieving equity is going to mean actually paying attention to what is equity from the patient's point of view. I mean, if we're going to try to achieve better outcomes for each and for all, we need to ask people what's important to them so that we're not, for you, achieving something that's important to someone else, but not to you. Do you want to say more?
Sure, yeah, well, you said it well. I think and early in my career, I did a lot of work with homeless populations and this, doing street outreach and working in shelters. And, it would be really interesting toggling from, that environment to a more traditional healthcare environment where it's like, okay, did you do the mammogram? Did you screen for colon cancer? And then, you have someone who's living on the street who, the things that they're likely to die from are, in like a small cohort of folks that we took care of over years was, things like exposure, murder, and other things that even if we knew all the things that they were actually at risk for, which had not been measured very well, and we were trying to scramble together data from that wasn't well organized, still, it's just knowing what is important for their health and what's important to them, which is often, safety and security and just a place to sleep for the night. We would sometimes have people who, I was working at the county hospital at the time, and sometimes it would take like 5 hours to get your medicines for your blood pressure or whatever. And at some point I realized that that there were patients who, if they went to the pharmacy right now and stood in line for 5 hours, they would miss the opportunity to get into the shelter for the night. And it was like January in Chicago, which for those who don't know, Chicago is very cold in the winter. And like the chances of them dying tonight were far greater if they stood in line at the pharmacy to get the medicines that I was giving them than if they got a safe and warm place to sleep. So, it just kind of scrambled my view on what we were measuring and why and how we needed to look at patient, population-specific needs and outcomes and also their input into the process to make sure we were getting it right.
I'll just add a dimension. Thank you for your question. I think about how few patients will say, I have time scarcity. But that's what we've done. We've asked them to take time to schedule the appointment, park, find public transportation, wait to come see us. And by the time they see us, the stress level has built up to get 10 different issues on the table versus in moments in the pandemic when we actually made things accessible. We brought the mobile van to communities, for example. Many cities across the US went house to house to bring out tests and vaccines and masks. And that stress level decreases and people began sharing. And I absolutely had this experience amidst the pandemic. More patients shared with me their social determinants of health. The fridge is not full. I cannot pay for the electricity bill in these moments. And I think the question is, how do we do that at scale? How do we have people have this convenient moment of interaction at the right time of day when they can get to the shelter, they can get to the public bus, they can make it to work on time, because we've rethought the sequence of how we're providing care.
Thank you. So I want to thank Drs. Lawrence, Weintraub, and Buchanan for their contributions today and frankly for the work that you do. We have compelling data now on inequity and health disparity at a population level, and there's no doubt that action is needed now. And some of the needed steps are clear, and we've heard some of those steps from this expert panel. Achieving a norm of equitable and inclusive care will require transformative change. Measuring meaningful outcomes for each and for all will drive faster learning and more insight. Measuring what matters requires knowing what matters, and we won't know unless we ask. We can achieve equity only if we listen to and honor differences in how people identify themselves, their priorities, and their lived experiences and circumstances. Healthcare exists to help and to heal, one individual or family at a time. So the goal isn't to offer equal services that work very unequally, but to achieve equity in improving health outcomes for each and for all. Thank you.